Okay, good evening, everyone. Welcome all audience to our first Headache Chapter series, which is done this year. As we used to do for you, headache is a very important topic in neurology. And as we know, one of the most common condition we see in clinics is headache. Most importantly, migraine headache. Today, we're going to be having the first headache series done by Dr. Caesar. Dr. Caesar is a neurologist, consultant neurologist in American Hospital. He had his American board certification a few years ago, and he had fellowship in neurophysiology as well. Today, he will be talking about migraine, social burden, and unmet needs. Dr. Caesar, the floor is yours.
Now, as we know, migraine incidence is one of the most common neurological diseases. And there were many studies that were done in many countries about the prevalence of the. So as we can see here in the Norway study, that again, prevalence of migraine was higher in women in all age groups. This is the red line for women and the blue for men, and again the black for both sexes. And here the migraine occurred most frequently in people aged 30 to 39 years, and that correlates with what we see usually in our practice. Here we're talking definitely about where the occurrence was the most, while in the previous study we were speaking about the cumulative incidence. In a study that was done in Sweden, they were assessing how much was the mean attack duration. And as we can see, the highest was between 4 and 12 hours. And then we can see the duration around that time, even sometimes reaching rarely more than 5 days. The mean attack duration was about 19 hours if we take all these numbers in consideration. Now, for the migraine attack, as we know, the migraine attack is divided into 4 main phases. And for the migraine with aura, it is 5 main phases. We have the premonitory phase, where people can experience different psychological and somatic symptoms that can tell them that they may develop the migraine attack. And that can be from some anxiety, insomnia, even some changes in fluid retention, even some changes sometimes in the temperature. So it can vary from one person to another. And then we have the aura phase in the migraine with aura. And then we get the headache phase, where we see that there is increase in the sensory hyperexcitability, meaning that people become sensitive to sound, to light, to odors, to different things. So there is excess of sensory excitability, while they get decreased in neuropsychological function, meaning they get more fatigue, they get maybe more anxious, they get more depressed, etc. And then we get the resolution phase, where the headache starts to resolve gradually. And then the post-drome phase, where some people can get drained out, can get very fatigued. Also, they may still have some sensory symptoms, some very mild headache, etc. Actually, some people do not recover between the attacks. And as per the postal survey that was done in Sweden, it showed that 43% of people can recover completely, while 43% mentioned that they are recovering more or less, but not completely. 9% of people did not recover, and then 4% did not reply. As we know, migraine prevalence worldwide is about, again, 10% of people. Actually, sometimes even it can reach more, as we can see here in Central South America, about 16 0.4%. Now, definitely, those statistics can differ also with the way it is taken. Global burden of migraine. Migraine has a big economic and societal burden. It contributes to 42.1 million years lived with disability, which accounts for about 4.8% of the global disease burden. If we are taking all the disease, including cancers and dementias and strokes, etc. As we can see here in the diagram on the right, the green is the migraine, and we see how much the migraine is contributing to the burden. The blue one here is the stroke one, and then the light blue is the dementia. So migraine is actually the second leading cause of disability worldwide, and it's the first among young women. Again, burden of migraine, as we can see, it comes number 2. Number 1, most of the time, is stroke, and then number 3 is Alzheimer's disease and other dementias. In some countries, actually, even it may reach number 1, as we can see here in West Europe. While worldwide, it is number 2. In our countries, it's number 2 also as well. And in North America is number 2. In UAE, headache constitutes a big burden again. It used to be in 2007 ranking as number 2 of the problem causing disability. In 2017 is number 3 after low back pain came to be number 2. A few studies were done in the region and in the GCC countries, and again, the migraine seems to be about 10% prevalent in some of the studies. In some other studies, it was less than 10%. But again, the type of study was different, and the way it's taken was different between those studies. When the prevalence of headache and migraine was assessed in school children in the UAE, again, it tends to be a big burden. So in Al Ain, the headache percent-wise was 37.8% in children. Migraine was 3.6%. In Dubai, 38.4 for headache, 4.1 for migraine. And in Sharjah, again, about similar numbers. Now, how much that caused family problems and school problems, we can see that for children without headache, the family problems was prevalent about 10.7%, while for children with headache, it sort of doubled. Again, for school problems, 14.1, in children with headache, 22.7, while amazingly enough, to see it in families where parents are complaining of headaches, it seems to be less. Now, definitely here, we're not talking about maybe hereditary migraine, where definitely we'll see the children much more. But in general, this didn't seem to be a big factor if one of the parents has headaches from time to time. Now, what are the migraine comorbidities? Migraine seem to affect big aspects of the person's social and work life and psychological life. So we can see that anxiety has a big prevalence in migraine people, and it's sort of double when it is chronic migraine for most of the psychological issues. So if it was 18.8, it increased to 30.2% in chronic migraine. Arthritis increased, bipolar disorder doubled, chronic pain again doubled, depression increased dramatically per 2 measures. And consequences of migraine on daily life, we can see the effects on sexual life, on love, finding friends, social position, time off, economy, family situation, managing studies, attending to work, etc. Career-wise, 32.7% of people with migraine reported that headaches had affected their career. And employment, 22.8% worried about losing their job because of migraine, which is a big number. Again, for children, 36% of parents with migraine felt that migraine affected their taking care of children. And actually, even the adult children with parents who have migraine complained in 8.7 to 13.1% that their parents' migraine affected their academic performance. Relationships, the same thing. 49% of people with migraine indicated they would be a better partner if they did not have the headaches. Again, for family planning, 3.2 indicated that they actually delayed having children or chose not to have children because of migraine. And we can see that migraine gives a big burden on the economic status. So we can see that the number of general practitioner visits increases, and that is affected by the number of days lived with migraine. So we can see the blue one is if it was 4 to 7 monthly migraine days, the light blue 8 to 14, and the dark blue is above 15. So we can see the effects on the general practitioner visits, neurological visits, ER visits, CT scans ordered, MRI ordered, and hospitalization. And the more we have migraine attack frequency, the more that causes a burden on the society. As we can see here on the diagram on the right, if the number of episodes was 1 to 3 or 4 to 5 or 6 to 7, how that increases the cost dramatically. Actually, it was estimated by the study was done in Sweden on 630 people that the average total cost per person per year is 10,000 euro 790. And about 80% are indirect costs. Now, preventing the chronification of the migraine actually can substantially reduce the direct costs. So if we have available treatment that can convert the chronic migraine to episodic migraine, we can see a major difference in the cost, as we can see here in the diagram, from 1,642 euros to 147 euros. Epidemiologic studies, including 27 members of the EU and Iceland, Norway, and Switzerland, showed that headache is one of the most costly of all brain disorders in Europe, as we can see here on the right. And we can see the direct cost and the indirect cost also in the blue. And we can see the headache that the indirect costs actually are much more than the direct cost. And it is one of the most neurological problems with cost in Europe. How can we reduce the burden of migraine? We had before preventive medications that can decrease the frequency and the intensity of the migraine. But again, those medications were not dedicated to migraine itself, and they were borrowed from other disease modalities. Some of them were antihypertensive, some of them were anti-epileptics, some of them were antidepressants, etc. And they were not targeting the main problem. Now, with the new medications that are targeting the main CGRP chemical, that has added a big factor in reducing the costs of the disease. As we can see, that the number of sick leave days has dropped dramatically. In addition, that the healthcare visits also has a drop after the invention of the new medication. In this Finnish registry of patients, it showed that the number of sick leave days has reduced by 73.9% and healthcare visits by 44.6% in the 12 months following treatment initiation. And also that has decreased the prescription of triptans by 30.4% and other prophylactic treatment by 31.5%. And also the indirect, as we said, the indirect cost actually sometimes in the migraine are more than the direct cost. In this German study that was simulating the cost of treatment with erenumab compared with standard of care, it showed that the erenumab reduced the burden of migraine by 166 million migraine days and the productivity losses by 26.6 billion euros per year, as we can see here on the right diagram. The incremental benefits of erenumab translate into nearly 118 million hours of paid work and 223 million hours of unpaid work activities per year. After this introduction, I will go over a few cases now. So the case one, MS, is a 34-year-old gentleman from Bangladesh. I first saw him in the 1st of August 2021. 3 years before that, he started having sporadic headaches about once every month or so that became more frequent and intense after 6 months from that, so about 2.5 years ago, and even much worse recently. So to a degree that was reaching 3 times per week, lasting 4 to 7 hours, frontal, throbbing, photophobia, phonophobia, etc. No nausea or emesis were mentioned, and it increases with stress. He didn't have aura. Zolmitriptan was helping at one time, but recently it was not helping anymore. He tried also amitriptyline only once, and it didn't give him any help. Topiramate 25 to 50 milligram daily for 2 years was not effective. 3 weeks ago, he was prescribed propranolol, which caused him insomnia and fatigue as per him. Otherwise, he did not have any significant other past medical history, no family history. Physical examination was unremarkable. Amitriptyline, I prescribed to him amitriptyline 12.5 milligram to be increased to 25 milligram, and then sumatriptan PRN. He came back on 22/2022, so about 6 months later, because this person also traveled. He does not reside in UAE most of the time. Apparently, the amitriptyline, even 12.5 milligram, caused him to be very sleepy, and he had to stop it after a few days. He was getting 3 to 5 attacks per month now, which is less than before. He was taking Imigran and then goes to sleep, does not do anything in the rest of the day whenever the migraine starts. So again, that even though the number of attacks was less than before, but it was affecting his life dramatically, because that day he will not do anything else. 2 days ago also, he had to come to the ER, and he was given paracetamol and Ketes. After giving this, he improved afterwards. He did not have any pain when he came today, and he was feeling better. We discussed his options, and we spoke about different options, and he decided to start with erenumab, monthly injections. He came back after about 2 months. He was fasting at that time. Amazingly enough, he said he did not have any headache whatsoever, even mild headache in those 2 months, when he was on the erenumab. However, with beginning of fasting, he had 4 days in a row of headache. He was sleeping well during Ramadan, 7 hours at night. He used to have 1 coffee and 1 tea before Ramadan, which he misses now. Otherwise, no other changes in lifestyle. At that time, I added candesartan, especially that blood pressure was somewhat on the high side. And I asked him to increase the erenumab this month to 140 milligrams. I called him up, after about 13 days. He did not have any headache since the last visit. He was checking his blood pressure regularly, and as it was normal all the time, he ended up stopping the candesartan 3 days ago. My plan was to observe after Ramadan, because as we know, for many people, Ramadan can be a challenge sometimes because of the difference in sleep times, the difference in also meals times, and sometimes also the habits that the person is having. In addition, sometimes to the effect of medications not taken in the regular times the person was taking. So, so my decision was to observe after Ramadan and to give him again the erenumab 140 milligram. And if the headaches were quite stable as before and no headaches and so, I may choose to decrease to 70 milligram. But again, the floor is open later on if any of you has a different comment, or he or she will choose a different approach. Now, case 2.
2 more minutes, Dr. Caesar.
I'm sorry. Okay. 42 years old gentleman from Brazil, came first time. I saw him in 2020, then later in 2021. Anyway, I'll make it faster. So this person was having episodic migraine with about 6 days a month of the migraine. He used propranolol and magnesium, which did not help. I prescribed zolmitriptan, was helping for the attacks in 90% of the time, and sometimes he needed to take the ibuprofen sessions. Propranolol did not seem to help. He took it for 2 months, and I chose the second approach to be the erenumab after discussing with him. And actually, erenumab made a big difference for him. So the number of attacks most of the time was about 2 brief attacks per month, and sometimes 1. And one of the months he didn't have any attack. However, the patient was later on choosing to, he was missing some of the injections on a few months. But again, with the major difference in his migraine incidence, we decided maybe after the first year to stop the medication and start with increasing the duration between the 2 injections to 40 days, 45 days, etc. And he seems to be doing well with that. And he mentioned actually in November 2021 that the past month was the best in his life. But again, he was sort of delaying the injections gradually. The main problem with the erenumab was the constipation, which was the other factor why we chose to also spread out the timing of the injections. I gave him the other options of choosing another, but for him, he said the decrease in migraine overweigh much more the results, the problems with constipation, and he chose to continue with spreading out the erenumab till he stops it later on. If I have another a little bit more of time, this is again a 50-year-old female from Brazil. Okay, so again, this is a chronic, I just mentioned, this is a chronic severe migraine that also erenumab made a big difference for her.
Thanks a lot. Thanks, Dr. Caesar.
Thank you.
So we go ahead with the next topic, which is held by Dr. Khalid Al Saffar, who's a consultant neurologist in Medcare Hospital, and he has a vast experience in many neurological diseases. Dr. Saffar's topic would be mapping the progress of real-world evidence in migraine prevention. Dr. Saffar, the floor is yours.
Perfect. Yeah. Thank you very much, Dr. Abubaker. Thank you, Dr. Cesar. Thank you, Novartis. Thank you all our audience for sacrificing their time in Ramadan. Good evening. I just want to speak about the new studies coming from the real-world evidence about the progress of migraine. We come here about targeting the monoclonal antibodies pathway to the global status. We see here actually the number of migraine people in the population, usually 1 in 10 people suffering from migraine. So the total number is 115 million of patients with migraine, and actually 7.8% they have high frequency episodic migraine, and 6.8% have a chronic migraine. And only 0.5% of those people are eligible for patient receiving Erinumab. So we are talking about the real world data these days, and we see now many studies are coming from different countries of the world here, and we are seeing many countries like for USA giving around 20 studies, and for Italy around I think 25, Germany 7, 5 from and 1 from UAE. One study from UAE. Actually, we have another local study which is not published or not mentioned. These all studies have included the effectiveness, the tolerability, the functional outcomes, and the quality of life, the health care resource utilization, and dose and route of administration. So, okay, it's not moving. It's stuck now. Okay. So what is the real evidence importance of this? Here, usually the real world evidence is the clinical evidence regarding the usage and potential benefits of risk of medical product that derived from the real world data. So if we come here, we see the real world evidence compared to the randomized controlled trials. So the difference is usually the real world evidence assess the medical product in a diverse setting of patient groups, while in the randomized controlled trials, it implies on a specific patient, specific number, a specific selectivity. And the medical product in the real world evidence, usually it's under conditions that reflect our real practice in our offices. It includes all the people that we give treatment, while the controlled trials usually assess the medical product in highly and tightly controlled settings. The real world evidence evaluates the long-term outcomes as long as we are using the medications, while the controlled trials usually it has a specific time frame. For example, 2 years with open label to 4 years, or to 5 or 7 years. If we come to the real world evidence and randomized controlled trials, usually they are meeting together and they are complementary to each other to have a better outcome of the treatment and of the treatment benefits. So it gives the treatment absolute value and its value relative to alternative interventions, and the real world evidence as well supplements and complements information collected from the controlled trials. The effectiveness of the control of the CGRP medications in the real world, we see here that this study coming from Italy It's actually, they recruited 372 patients, and these patients were all treated with Erinumab 70 milligram once a month, and the enrolled patient, all of them had failed 3 or more classes of migraine prevention medications. And we see here the results. We see that there is, from this group, there is 38% in the episodic, high frequency episodic migraine in the first graph. We see these columns that there is 38% response in these patients, and there is a 75% response in the first 4 months, while in the second 8 months, in the same group, who are actually failed for other medications other than CGRP, in the 8 months in episodic migraine, there is almost 45% and 50% reduction in monthly migraine days, and 19% reduction, have 75% reduction, and 2.9% have full response and no migraine monthly days. While after 12 months, we see there is up to 60%, 50% reduction, and 16% who have 75% reduction, and 1% they have almost full reduction, 100%. If we come to the chronic migraine, the number of patients enrolled were 269, and we see there is 46% reduction in the monthly migraine days in the first 4 months, and 17% have 75% reduction, and there is no one had in the first month for a month that's 100%. While if we come to the 8 months, we will see that there is a 54% reduction in the monthly migraine days and 50%, and there is 21% of the patients have 75% reduction, and 0.8% have 100% reduction. And in 12 months, we will see up to 55% have 50% reduction, and 22% have 75% reduction, and 1% have actually 100% reduction. So to see how effective is the treatment here. And here we see the conversion from the chronic migraine to episodic migraine in this group. This is from Italy, the study, and the number of patients were 155 patients. Usually we are interested to mention these studies because these studies are very recently published. They are just within last 10 days or 2 weeks, these studies was published. So this data includes the patient fulfilling the definition of chronic migraine for 3 months preceding the Erinumab treatment, and with at least 6 months of follow-up after treatment. And we see here, and this there is the baseline is 100%, and we see there is 68, almost 70% of patients who are converted from chronic migraine to episodic migraine in the first 4 to 6 months. Here we see this study from Germany is showing that the effectiveness of Erinumab in refractory migraine who failed to respond to all the other preventive medications, and the number here were 100 patients, and the number here actually include 26% episodic and 74% chronic migraine, including 66% the medication overuse. At 3 months, there is 57% episodic migraine plus 41% chronic migraine had a 50% reduction of the monthly migraine days. And there is 52.7% converted from chronic to episodic migraine, whereas there is 46% has no medication overuse headache, which is highly, valuable and substantial benefit. And here we see the Erinumab again is effective in people who had failed to the Botox, to the botulinum toxin A. And this study, one comes from Spain and the other came from UK. And both of them had shown that there is, for example, the Spanish study showing partial and non-responders to botulinum toxin A can benefit from anti-CGRP monoclonal antibodies preventive medication in the real-world evidence study. And again, in UK, there is improvement in the study showed that there is mentioned in the Journal of Headache and Pain. This showed that improvement in pain medication use and quality of life in botulinum toxin A resistant chronic migraine patients following erenumab treatment. Here, the tolerability of the calcitonin gene-related peptide monoclonal antibodies in the real world. We see here the persistence of treatment. This is a study coming from Canada, and this showed a retrospective study enrolling 14,282 patients. 83% were females and 17% were male. And they showed that there is 71% persistent to erenumab in 1 year after treatment initiation. And they showed also there is 60% who initiated treatment and the treatment is escalated from 70 to 140 milligram within the 36 days or 1 year. So either the one continued with 70 and the others usually shifted to 140 milligram, and they have a good persistence over 1 year. We are coming to the interruption treatment actually with the CGRP, because all the people, the first studies came when these medications launched, usually first for 6 months, then extended to 1 year, then they extended the studies open label up to 4 years, and it showed the same result after 4 years. And here we see that some patients were stopped their treatment after 1 year as just giving the drug holidays. And this is what we have done actually at the start of our treatment with monoclonal antibodies. And we see here, again, the study, this includes 52 patients from Switzerland. And the data analyzed from patients with episodic and chronic migraine who were treated with monthly injections of monoclonal antibodies for 12 months. And the data collected from 5 study centers, then they are around 90% females and 9% up to 10, maybe 10% males. So we see that the days, the monthly migraine days, and the episodic migraine was 14 days at the baseline at the start of the study, ±7, and the chronic migraine, there are 20 days, monthly migraine days, ±5, which is almost 21. So after 3 months of treatment, we see in episodic migraine, the monthly migraine days came down to 5, and which is definitely less than half. And the same in chronic migraine, it may be less than up to third, the basal number. And after 12 months, we saw that there is further reduction of the monthly migraine days in both episodic migraine, because it came to 4 days, or 4 days also in chronic migraine, which is around a fourth of the baseline migraine days. If we come, when the patient interrupted or stopped their treatment, there is recurrence of the monthly migraine days. It's raised back again up to 8 days. But and 5 days still in the chronic migraine, which usually we see the response in the chronic migraine is better than even in our practice that the episodic migraine. And after the second month of stopping the treatment, there is 9 days. It is again raised more in episodic migraine, and it is 8 days again. It started to raise up, and then in the third month after treatment interruption, in episodic migraine, we have 12 days, while the baseline is 14 days. Again, it raised back, but it is not as the baseline. The same as for chronic migraine, after 3 months, is still almost half of the monthly migraine days. And we see after treatment restarted, usually we see that, again, the monthly migraine days after the first month start to go down gradually. And in the chronic migraine, it has also a very nice response that it came back to 5 days as if it is in the first time when it started. Here is showing the same study, but actually this is from Italy. And the number here is 295 patients. And to see here the 1 month follow-up after they stop the treatment, they raise up to 33%, and then the 41% the monthly migraine days for the chronic migraine. And we see for the medication overuse after treatment cessation in the first month, again, it raised back to 18 monthly migraine days, 18%, and then the 31% after second month and 42% after the third month. So when you stop the treatment, the number of monthly migraine days is increasing back again, but actually after 3 months, it never reached the same basal level before starting the treatment. Here, the chronic migraine with medication overuse evolution after treatment cessation. This is a study coming from Italy, and the number of patients enrolled were around 185 patients. And we see here in the end of the year, usually there is 20% the monthly migraine days. And again, it is after 1 month cessation, it increased up. It is the same idea and the same actually the things that we showed in the previous slides. And after 1 year, it is 12 monthly migraine days after 3 months suspension, it raised up to 18. The real-world experience with Erinumab in UAE. Actually, all of you we have seen these studies. This study is done by our colleagues, actually from 3 medical centers. 166 patients were enrolled under the supervision of our colleagues, Dr. Abubaker and Dr. Tawfiq Al-Saadi, and usually they were given 70 milligram and within 6 months, and they have the potentiality to increase the dose to 140 milligram. And the people the patients recruited, 57% were episodic and 43% chronic, including patients with medication overuse. We see here the interesting thing in this study, it's matching the international figures, which means that this is consistent benefit among all races and groups of population. All ethnic groups have the same, because all the studies have the same results. So we have overall 78% having 50% reduction and 62% having 75% reduction in monthly migraine days in 6 months. And there is among the chronic migraine, we have 95% reduction, 95% of patients have 50% reduction and 72% of patients having 75% reduction, which is the same of all the international studies. And the chronic migraine, actually the use of daily medication had reduced from 18 days into 7 days in 6 months. Does this confirm this Erinumab efficacy and safety and tolerability the same as in the real world setting? And here, this column showing the same, what we have mentioned. We don't want to waste your time. And here we come again, there is a 72% reduction of 75% responder to 72% reduction of monthly migraine days in 6 months. We come here to this other study. This is not mentioned in the real world. Actually, this is from our colleagues in one of the private hospitals. Again, the same rules, the same parameters, the same study, and they use the same doses of the same period of time, and the response rate was in actually showing again the same. Here we can see 80% have 50% reduction and 70% have 75% reduction in the monthly migraine days. And here we see 85% reduction, 85% have and 50% of patients with chronic migraine and medication overuse achieves 50% reduction. Here we see that erenumab again proved its efficacy worldwide. We are, if I am not late, I'm not actually, Dr. Abubaker, can you allow to see my two cases are interesting?
Yes, go ahead. You have 8 minutes.
Yeah. This patient, he is a local patient. He's a male, 34 years old. And he presented to our clinic in 2018 with headache of 2 years duration, with all the criteria of chronic migraine. Actually, it lasts 5 months. He has continuous body quality of life, continuous headache, body quality of life. 2 days in a week cannot go to his job. All other days has bad job performance. He has bad family relationship because of isolation, avoiding light, sounds, and bad sleep. So he had failure of 3 preventive medications. The Topiramate gave side effect. He couldn't tolerate the early in the treatment, and the propranolol, amitriptyline, and cloimipramine all failed when given separately. But better on combinations, he had some partial improvement on combination of amitriptyline and propranolol. So we started the erenumab. It was given in 70 milligram once monthly, where it's an obvious significant improvement, but still the days of headache are around 10 or 9, and in between there is no full, he's not fully comfortable. And actually 3 months later, we gave him 2 injections of 70 milligram because that time 140 was not available. It was given when he did obviously a satisfactory response. He had only 2 monthly migraine days, and the attacks are very mild, brief, responded to diclofenac powder. There is, he did not show up in our clinic for 2 years. And later, just a few months later, he came again. When we asked him why, he said, propranolol 40 milligram after 1 year of erenumab. This 40 milligram taken twice a day, I am just taking an over the counter, and it was enough to continue as preventive medication, and he was happy all the time. He came now because of recurrence of the severe again migraine, the same one as started before, but this came because of a significant and substantial job stress he is exposed to. And then we started erenumab back again, and actually he did very well. Just I'm just showing these cases because they are matching our highlights that we mentioned in our study. The second case, she is a lady, she is 65 years old, and she is a university staff here in UAE. She has more than 10 years history of severe headache, typical of a chronic migraine, almost daily. She is using combination of propranolol recommended by a friend. Just she went to a condolence meeting when one of her friend told her that why you have headache. She told her, I have migraine. And then she told her, take Inderal, it's good. And she tried that. And then she continued at that because she has some every now and then better benefit, not persistent. Then she added amitriptyline. All these actually medication given not by a physician, given by friends. This is recommended by her surgeon when she was doing one of the surgery, and the surgeon was following her, and she told him, I have migraine, and he advised her to take the amitriptyline. So she came to me. Actually, she has minimum 1 to 2 days per month absence from her duty. Usually she has a problem during the rest of her duty hours, but she has been already on propranolol and amitriptyline. She is reluctant to travel with her family during summer holidays because of severe continuous headache. During her journey, she cannot take any cruise because actually she has a motion sickness and usually reflected to have later into severe headache, and she should be in bed. So when I saw her, actually, I suggested the Topiramate. She did not take it, actually, and she refused to take it. And she fought with me, saying that, why you are giving me anti-epileptic treatment? Try to discuss or to explain. She actually refused. And then she rejected the Botox because she is using the Botox for cosmetic reasons, and it is not giving her a significant benefit. So after a while, she left my clinic. She did not show up. After 3 months, she sent me a message in my phone saying that I heard about the new medications, injections. Are you willing to give me this? I told her, yes, you are just recently launched in our country. And actually, you are entitled to it. You have a very long record and you have failed many medications. So you have to take it if you want. We are ready. She came to the clinic. We started 70 milligram Irinumab. It was not very useful. It has partial usefulness for her in reduction the monthly migraine days. But then after 4 months, I actually gave her 2 injections of 70 milligram. Actually, she had a magic response. She's very happy after the 2nd month of the 140 milligram. And she went to Nile cruise with the family for a New Year celebrations in Aswan in Egypt. And she was very happy, even no motion sickness and no headache. She stopped the treatment after 1 year. And 3 months later, actually, she started to have the headache because 3 months she did not take any medications. She stayed on propranolol and Amitriptyline, but after 3 months, she came again. The attacks were started to be severe, and the number of headache days started to rise again, and more than the baseline. So the treatment was restarted again, and now she's been on Irinumab 140 milligram for maybe last 6 months. Thank you.
Thanks a lot. Thank you a lot, Dr. Khalid and Dr. Caesar. So we had few questions here. I answered most of them. One of the question is there any new effective painkiller for GPs to be used other than Migraine and Rizatriptan or Zomig?
I don't know that. Can I answer? Hello?
Keep in mind that this is a question which is asked by GP. So they cannot write Rizatriptan or Zomig or Migraine.
Yes, I think that we have the Lasmiditan, the Revau, but it has a specific, indications that usually I advise my patient because it causes some unsteadiness of the gait and dizziness. Usually I keep it for the last resort. We advise our patient to take as early as possible the Triptans. And we have a new Triptans now, which is the sublingual. It is very, very important to be taken, especially in Ramadan. And it's not absorbed through the stomach, not going through the intestine, only in the mouth, absorbed, and is a very, very rapid. It is just like the Zolmatriptan. It is the same as Zomig, and this is good. It's available in the market, in our market in Dubai, and we have the Lasmiditan. If there is no response to the first medications, either non-steroidal or the Triptans in the first hours, then, and the headache continue, we advise the Lasmiditan, the Revau, and that they should try it because it has, because some patients are transferred to the hospital if there is no response. To avoid hospital emergency intravenous medications, to stay at home, lie in bed, watching TV, and take the Revau. This is my advice to some patients.
And soon we will have the Jepans as well, hopefully, so that will add to that.
The question was requested by family physician. So I don't believe they can write Migraine, Zomig, and all these. So my advice for him or for those non-neurologists would be, well, Brufen is good acute pain medicine. You can sometimes combine it with antiemetic to increase the absorption. So I found that if you put Immigrant or NSAID along with
metoclopramide,
preferably a Voltfast or something which is absorbed, along with metoclopramide, the effectiveness of absorption and controlling the headache is much better. Of course, if they cannot use things like Triptans and Reva or Nurtec. That was one. Dr. Qaisar, question for you. Is there any useful prophylaxis we do for migraine headache?
Is there any prophylaxis?
Yes. What are the prophylactic medication we can use for migraine on GP level?
On GP levels. Now, there is the propranolol or Inderal. There is the Amitriptyline. So we need really to look for if the patient has other problems or is complaining of other symptoms. For example, I may choose if a person has problems with sleep as well, and not necessarily having any problems with weight, I may choose Amitriptyline, for example. Now, if a person has no problem with asthma and the blood pressure is not very low, I may choose, for example, propranolol. Now, Topiramate is another option that we can use. Topiramate, we need to keep in mind that it may cause some weight loss, which could be an advantage sometimes for some people, but at the same time, it may cause sometimes concentration problems, some numbness, some insomnia. So we need to work around it, give it in the morning, etc. This is another. Some of other antihypertensive like candesartan or losartan or so can sometimes work. Magnesium sometimes can play a role sometimes as an adding factor, I mean, as a supplement that can help in the treatment sometimes. Sometimes I find really for short time, definitely not for long time, I find tizanidine or sirdalut sometimes, especially if there is a cervical component, especially if the person is complaining of occipital migraine and cervical migraine, and there is a lot of neck stiffness. So sometimes for short time, tizanidine can be a good medication.
Perfect. Excellent, Dr. Qaisar. Dr. Khalid, what's the difference between migraine and cluster? And how is the treatment different?
Cluster headache has a special, special clinical criteria. We cannot say it's similar to migraine. A cluster usually in our clinical practice, it is coming in several weeks time, and it stopped for another year or another 6 months or another more than 1 year to come in the same in the clinical constellation. So it is very severe, and it's mostly unilateral, and it has associated with some tearing eyes, runny nose, flushing of the face, numbness of the face, and it is very, very severe. And usually it is more in male rather than female, while you see the migraine is mostly in female more than male. So this is the mostly clinical criteria, and the treatment again is different, because actually before, when we don't have the current medications these days, we used to treat some of our patients before, because the patient can say that the headache is coming 1 o'clock afternoon. And every day that the patient in the several weeks, what we call a cluster, it's coming in the same day, in the same, actually daily, in the same time. So we advise our patients before to take for example, the Triptans or the medication that he can make use of early or half an hour or 15 minutes before the start of the timing of the pain. And that was before. And later, the oxygen is very useful, 100% oxygen, and now it's available. And many of the patients, and we have one patient, he is in a critical job. He did not get benefit from any medicine but oxygen. And he has his oxygen cylinder, which is small, and he can carry it out with him at any time. Once he expected, he put his mask of oxygen for 100%. It's useful. The verapamil medications actually is useful in some, if you give high dose of verapamil 80 or 160 milligram twice a day, it is very useful also in some group of population. And now there is one of the anti-CGRP was actually approved to be useful, and again it is useful, the galcanezumab, actually, which is given in a special and 100 milligram syringe, but given 300 milligram once a month. And this is very good success in the treatment of a cluster, because before there was no significant cluster headache treatment. And it is very exhausting when it becomes severe and if it is not responding to treatment. So we differentiate by the clinical constellation, clinical presentation, and by the response and by the follow-up.
Excellent, Dr. Khalid. And most importantly, cluster headache is less common, less duration, autonomic symptoms, and it's very severe headache usually.
Yes.
They compare it with the delivery pain. So one of the most severe pain.
Okay, yes.
Cluster headache pain, delivery pain, and cancer pain.
Okay.
So how long would migraine injection last? I think he meant the CRGP injection, how long it lasts. Dr. Qaisar?
Basically, we are using them on monthly basis. There is another one which can be given every 3 months, but the usual ones, erenumab and galcanezumab, we are using them on monthly basis.
Okay, good. So usually
I'm sorry if the question is the duration, could be the duration of the treatment.
Yes.
The duration of the treatment, in most of the time nowadays we are using 1 year and assessing. I mean, some people are taking it really for more than that, but in general, if the person responded very well to 1 year, also many international studies showed that we can start stopping them after 1 year. But again, if the person again restarted having the headaches, we need to use them for longer than that.
Okay. Dr. Khalid, if Enderal or Topiramate are not effective, which drug is useful? And is there any permanent solution to stop the migraine?
We have as Dr. Qaisar mentioned early in the earlier questions, that in his answers, that there is actually I have to add the flunarizine. Flunarizine is not available in UAE, but it's available in our hospital because you can request it. Every physician can request, and the pharmacy of a hospital can just bring it to the pharmacy, and we have it. And actually it showed very good response. Flunarizine, called before Sibelium. It is not allowed to be used in USA because they have studies, actually very low percentage that some people, they develop Parkinson's. That's why they stopped using in USA, but it is used in Europe. In Europe, it is available, and we are using it here, and we don't use it for a long time. So I don't think there is a place for Parkinson's disease, and usually it is used in young population. I'm using not only the amitriptyline, I'm using now the cloimipramine, which is very useful, the anafranil. We have 10 milligram and 25 milligram. We give one at night, and we have actually the imipramine. I saw it more useful than the amitriptyline because it has less side effect, less drowsiness next morning, and it gives better response. But actually, again, is not available on wide level in our pharmacies. Only the hospital can request it for a special request from a special doctors, and can request it on its own, not through the national route. I'm using the anafranil, I'm using the imipramine, I'm using the flunarizine. I think they are, and you know, as we mentioned before, that there are some other areas. You know, some of the females now we saw they are using the Botox for cosmetics from the aesthetic people, from aesthetic medicine, and they are coming to us. It is not given in the proper way as we give in migraine, but actually they have some partial response. And they said, okay, I did my Botox with my plastic surgeon or with my dermatologist, and the headache is less. So these notes, just I want you to know about that, and maybe it may be useful.
Dr. Caesar, any natural therapy, alternative medicine for treating migraine headache?
There are some let's say supplements or some herbs, and can sometimes add to the effect of the medications, but that depends. If the migraine is very severe, frankly, we need to use other alternate. We need to use the formal medications, but those can add an additional effect, such as sometimes, again, the magnesium, coenzyme Q10 can sometimes play a role. Feverfew. Sometimes it's mentioned that ginger, for example, has some anti-inflammatory effects. So sometimes also increasing the ginger in our diet and all that can sometimes play a role. This is what, frankly, I'm aware of. But I think there are a few more herbal medications that can be additional with the mainstream treatment.
I found acupuncture, riboflavin. As you mentioned, magnesium can be given, especially in pregnant women. At times, trigger point release, I found it's good, especially if you have tension component.
Now, in the West, they mentioned too much feverfew, but I don't know if it's available here. I don't know if any of you prescribed it sometime or...
It's available. It's called in Arabic, Zahrat al-Qawan.
Okay.
The patients actually told me. Okay, Dr. Khalid, does migraine damage the brain?
Maybe, I don't know, but I don't have a real idea about, but you know, all our migraine patients, when they reach some long age, long time they live, but I don't think that there is any, because you know, after when they have become seniors, actually the migraine is starting to be less. So this is one. And secondly, we can just have some conclusion when we look at the MRI of some patients with severe migraine. We can see sometimes that there is some white small spots, just like what we see in atherosclerosis and maybe arteriosclerotic evidence, or maybe the Virchow's notes that we actually know about that in the brain. So either some report as inflammatory or ischemic, but actually it is not the number enough, even when they are confluent, to have any residual things in the future. So I don't think migraine, it is a damaging disease. That's my opinion, because according to my observation, long time with patients with migraine, even after they have their migraine process burned out, I don't think that there is any significant, maybe there is some damage which is does not cause any functional and not any clinical manifested evidence in the future.
In some data show that in cryptogenic stroke, migraine with aura could be one of the possible causes. But it's not definitely confirmed, as you mentioned.
Causes. Sometimes it's as theory, I think, more than to have real data of that.
Dr. Caesar, any natural therapy for migraine rather than medicine or alternative medicine? Anything they can do to help them controlling the migraine?
I mean, definitely lifestyle plays a big role. So making sure to have enough amount of sleep is usually recommended. Again, certain food in some people can attribute to the migraine. So we need to avoid those food, for example, chocolate, cheese, sometimes too much eggs, canned food, too much coffee, wine. All these can play sometime role in some people, but definitely not in everyone. Regular exercise, daily exercise can be good. Having relaxed life, doing relaxation techniques. As you mentioned, sometimes acupuncture can be a good alternative treatment as well. I mean,
I think, Dr. Caesar, about sleep that we have, this is, it has, migraine patients have a different response to sleep. Although in the majority, sleeping better, preventing migraine, but we have some group of patients who have the migraine after long sleep. And we have some group who are coming to us saying that I have the migraine only during the weekend, because during the weekend, they are sleeping a lot. So after long time sleeping, some of the patients, they have this sleep, long sleep, triggered their migraine. But in general, what you have said is true, that in general, our recommendation to the patients is to sleep, to have enough sleeping hours, just to avoid the lifestyle and the stressful life. Again, and less sleep is a significant contribution.
One important factor here is the diet. It's written in the books. It doesn't apply to all patients, but
yes,
diet control,
yes,
especially milk dairies, greasy food, spicy food, may help in some majority of people who have chronic migraine headache.
Yes, and there are some patients, Dr. Abubaker, if you don't mind, that there is some patients, actually, they have their own food that it is not listed to trigger their migraine. For example, one patient came, whenever I eat tomato, so which is, I haven't heard about it, but the patient is proving that he is, whenever he eats, he has this, the orange juice, and some patient, they have the orange juice. So we just list to the patient the major group, as you said, and as Dr. Caesar is said, all are true, that the coffee, the dairy products, but we can tell them also that there is some food that you can experience by what you are eating, followed by migraine. If this is reproducible and regularly, stop that food that we don't know about it. So that's what I just want to clarify.
And we should not forget that some patients also get migraine headaches whenever they miss their meal. Also for some. And again, the sun can play a major role, change in temperature between hot and cold weather also in some people can be very sensitive to that.
Yes, yes.
So,
yes.
So one question here, is there any role of birth control pill in provoking migraine or preventing migraine?
No, I think it is opposite. We have some patients when they are coming, when you ask them why this new headache, actually it's related to the hormones. That's my experience. I don't know, because some people, once they stop, who have a recent evolution of their headache, of their migraine, and we ask them, it is actually matching the start of the new contraceptive. And once we ask the gynecologist, or if she can stop that, to switch to other contraceptives methods, or to give a less hormonal tablets, maybe they get better. But I did not hear about myself. I don't know, only that's up to my knowledge, that I haven't come across that we give contraceptive to prevent migraine.
Right.
I fully agree with you. Although theoretically, oral contraceptive is a steroid, right? It's like sometimes in migraine, we give steroid. But ironically, if you take or if they start using OCP, they may provoke their headache in majority of the patients. Dr. Qaisar, do you agree with this or?
Yes, sure. Yeah, sure. We see it. Many people will have their headache start after they start their contraceptive pills. Yes.
I think we finished on time. Thank you very much, Dr. Qaisar and Dr. Khalid, for your very interesting talk. We promise the audience to have more series in the future and this year, of course. So the headache chapter will be a very interesting one. Thanks a lot, everyone. Thank you.
Thank you. Thank you.
Thank you. Thank you very much, Dr. Abubaker.
Thank you.